All right. Thank you, everybody, for coming. We're really happy to have you today. My name is Dr. Stiep. I'm one of the Movement Disorder Fellows here at UF. I'm a board-certified neurologist that now specializes in movement disorders, and I see a lot of Parkinson's disease. So I'm really happy to be here today to kind of give you a talk on Parkinson's medication specifically, okay? All right, so I think the first question before, we really start talking about medications, we should really start talking about whether we should start medications and when we should start medications, right? So the question is to start or not to start, and when is it the best time for us to start medications for Parkinson's? Usually we say, any kind of impaired function, whether it's an ability to perform tasks, you find it hard to write, anything that's going to affect your day-to-day life, anything that you feel like it's hard to move, hard to do. It could be work, it could be, sometimes as much as, your tremor is visible and it's impairing you from like going out to a restaurant because you feel embarrassed, any of those things. That takes a toll on you physically or even emotionally because of the symptom, I think, and anything that causes loss of enjoyment of your day-to-day life, at that point might be a time to consider a medication. Also, if anything is interfering with your ability to stay active, okay, we want you to stay active, exercise, continue to do the things that make you happy and active, because the most important thing with Parkinson's disease is to keep you moving, keep you doing the things that you want to do, and the most important is exercise, and we don't want anything to interfere with your exercise regimens, okay? Also, we want you to have a good quality of life. We don't want Parkinson's disease to really take a toll on your quality of life. So if you feel like your quality of life isn't so good, might be a time to, consider a medication to start. And then the other things that we sometimes neglect with Parkinson's disease is the non-motor part, right? Everyone talks about the motor symptoms, the tremor, the rigidity, the stiffness, but we sometimes don't really talk about the other things like mood, sleep, that also can start to, detract from your everyday. And if that starts to become a problem, it's another, time to consider, is there something for me, to be able to do about this, okay? So why does medication help with Parkinson's disease? So we know that with Parkinson's disease, dopamine is a very important chemical in the brain, and it's reduced in Parkinson's disease. Over time, the cells and the neurons that make dopamine start to kind of not be there, not make dopamine anymore, and so you're losing this dopamine in the brain. And what most of the Parkinson's medications do, it's either it replaces the dopamine that you don't have anymore, or it augments the dopamine that you do have or helps it work better in the brain, okay? LEVODOPA, which is our mainstay medication you've probably heard about, alone is the one that kind of replaces that dopamine for you. Dopamine can have some side effects, right? Nausea, vomiting. So that's why we add the carbidopa to the dopamine, and that kind of helps it work and prevent these side effects. Other medications, like I said, other than the levodopa, which replaces the dopamine, kind of works either as a adjunct or as a sister to the dopamine, or it helps the dopamine receptors work, okay? And it adds benefit. All right, so what symptoms do we know for sure are improved by adding this dopamine into the brain? So stiffness is improved, slowness of movement, tremors can sometimes also be improved a lot by dopamine, but sometimes tremor can be a little bit finicky too and can be the symptom that might be a little bit resistant to dopamine, okay? Also fine motor tasks, being able to write again, being able to manipulate small things like buttons can be a little bit more feasible once you're on medication or the dopamine is on. Also, it can improve gait, but more so the gait speed, because like I said, it improves either the fluidity of the movement, like if you're really stiff, it kind of makes your movements a little bit more fluid, and it can improve the speed of your movements. But if balance is a problem, like you're starting to feel unbalanced, or you're falling because you're losing your balance, the dopamine isn't going to make a huge difference in that realm, okay? So this decision time to make, this choice to start the medicine or not start it is really up to you and your physician, your doctor, whoever it is that's treating you. The choice is by every individual, and every individual's time is different, Whenever you feel comfortable, whenever you feel like your symptoms are really interfering with your day-to-day, your quality of life, any of those things, that's the time to really talk about, is it right for me to start medication? Or, is it time for me to change my medication, to add something like that? So that every patient is different, and every patient is going to have a different course throughout their disease. Okay, some people start medications as soon as they're diagnosed because it's the right choice for them. Others will take a couple years to start medication because they feel that's comfortable for them. Okay, and I want to kind of emphasize this. Everyone with Parkinson's disease is their own person, and we treat everyone as their own person, and we don't kind of go, everybody is the same. So I really want to emphasize that everyone is unique, and your symptoms are unique. You might have some of this, you might not have a tremor, you might have stiffness, but it is very much, we're kind of trying to gear our treatments to you specifically during our visits. You might notice we ask a lot of different questions, but that's just so that we can tailor the treatment to you, okay? So we'll start with the actual medications now for motor symptoms. So I want to start with the one that we all know, the one that is our gold standard, LEVODOPA, or aka SINEMET. SINEMET is the carbidopa-levodopa, but the real active ingredient or the active part of the carbidopa-levodopa is the levodopa part. If you can see in my figure here, so levodopa and in itself, for instance, if I was to give you a pill with only levodopa, it would stay outside of the brain. It wouldn't be able to cross into the brain. So that blood-brain barrier that we have that protects our brain from chemicals, from infection, all these things, is pretty closed off. And the levodopa can't cross into the brain by itself. The dopamine, if I was to just give you dopamine, it would not cross into the brain, so that's why levodopa is able to cross into the brain. Once it crosses into the brain, then your own brain turns it into dopamine. So that's how it is essentially just supplementing your dopamine. The other thing about levodopa is that if you just given levodopa, you might feel really nauseous and upset stomach because it also acts on the gut and other parts of the rest of the body, and that carbidopa part kind of allows it to just go straight to the brain and not stick around in that other part of the body that causes these symptoms like the nausea. So sometimes if you're having a lot of nausea, a lot of side effects, whenever you take the carbidopa-levodopa, we might give you a little bit of extra carbidopa to kind of help with that. Okay, and this is one of our oldest medicines. It's been around since the 70s, and it's still considered our gold standard medication. It's the one that we always go back to for Parkinson's disease. Okay. Have you guys ever heard of the levodopa controversy? Or maybe a couple of you could tell me what you've heard or what your...
If you started too early, it will stop working.
Okay, that's definitely one of the questions that we get very often and one of the controversies.
Regardless of when you stop it, it loses efficacy over time.
Okay, we've heard that one too. So all of that is very valid, and it's one of the reasons why some patients really hold off on starting levodopa for a few years. And through research, we've kind of been able to hammer out some of those questions and kind of be a little bit more clear about what actually is going on when we talk about levodopa, okay? So you've mentioned starting too early and then not working out fast, not working later. These are some of the things that we've been told. I've been told to hold off on starting levodopa because it's not going to work as long, you know? Or I was told to not start levodopa so early because I might get side effects. You know, those wiggly movements that we call dyskinesias. So that's the other fear. But from these studies that have been going on for many, many decades, we've learned that the most important thing is that starting levodopa early is not going to worsen your Parkinson's disease over time. It's not going to make it progress faster, and it's not toxic to you in any way. Okay, so that's the number one. And number two, another study looked at over 800 cases that patients had access to levodopa early, or had access to levodopa for the a good portion of their disease. Also extended life expectancy in people living with Parkinson's disease. Especially those treated before they started to have a gait impairment. Okay, gait impairment is usually one of those symptoms that kind of tells us we're kind of in a little bit of a more advanced stage of Parkinson's. So if you're able, this study showed that if you start levodopa before this later stage of Parkinson's starts, you tend to have a little bit better outcome overall. We mentioned the dyskinesias. If you start levodopa early, are you going to develop the dyskinesias earlier? The answer is no, actually. A collective summary of studies showed that it's not the time that you start the levodopa, but rather the length or the amount of time that you've had Parkinson's that really dictates when you're going to have dyskinesias, okay? So specifically, there's a study that looked at it, and we looked at patients who had Parkinson's disease for a certain amount of time, some that started the levodopa earlier and some that started it way later because they just didn't have access to levodopa, and they all ended up having dyskinesias around the same time. And it was because it's not really the amount of time on the levodopa, but the amount of time that they have Parkinson's disease that really dictates the side effects of the dyskinesias, okay? And the big question, will it stop working over time? And also, the question to this one is no. Okay, the levodopa does not stop working over time. It's just that the progression of Parkinson's disease gets worse over time. So the way that the levodopa is helping you is going to be different, right? So let's say when you're early in Parkinson's disease, you're making maybe this much of dopamine already, and so we just need to bump you up to here with the levodopa for it to work, right? But as time goes on, and at the beginning, you're still making some dopamine, right? So you still have a little bit of a reserve, and you're able to keep it around also, right? But as the disease kind of progresses, you're making less dopamine, and you're needing more levodopa, just because you don't have a reserve, and there's no way for you to keep a reserve, okay? And that's when you start needing more levodopa, more times, shorter times between doses. But it's not a measure of how long you've been on it. It's more of a measure of how much dopamine your brain is actually making over time, okay? All right, so the pros of levodopa. One, it's cheap. It's been around for decades, and we're easily can get it, right? It's the best medicine that we have for stiffness and slowness. It also has predictable on and off, meaning you take the medicine, maybe half an hour later or an hour later, it's going to work for you, and generally it's going to come off either 3, 4, 5 hours later, depending on where you are in your disease, okay? So it's pretty predictable. The pharmacology of it is really reliable, okay? It also starts working faster than the other medicines that we have in the market, okay? So the onset is faster. And we are easily able to go up on it based on your need, okay? So it's pretty easy to find the right dose for you. It also shows that it's the one medicine that gives us the greatest improvements in quality of life as well. And it's our tried and true, like I said, it's the gold standard for Parkinson's disease treatment. What about side effects? What kind of side effects can we expect with levodopa? Usually, the most common side effect that we get is nausea and vomiting, especially when you first start it. So, your doctor is like, okay, we're thinking it's time to start dopamine replacement. Let's start levodopa, and then the first week you take it, you're sick the whole week. It usually takes a little time to get used to, but then also we have some things that can also make you feel better if you are having a lot of nausea and vomiting or nausea. One of the techniques that we usually recommend is to eat something with it. It could be a carb, especially in the beginning of your disease. There isn't a lot of food interactions in the beginning, and the food interactions we kind of worry about later on, and it's more protein that we kind of generally worry about. The other symptom that we worry about is what we call orthostatic hypotension, and that is when you go from sitting to standing and you get really lightheaded and you feel like you might pass out. That's the symptom that can sometimes get a little bit worse or get a little bit, you can get a little bit more lightheaded with levodopa, okay? Because that blood pressure can't, keep the blood pressure up, and that will cause the lightheadedness. The other one that we always think about is dyskinesias, those wiggly movements. That can be a side effect of levodopa. And then sometimes you can have some mood or even like psychiatric manifestations like paranoia, hallucinations, especially when you're on the really high doses, not so much on the lower doses.
Do you know the incidence of some of those things off the top of your head?
I don't know the incidence, the specific incidence. I know that the nausea and vomiting is by far the highest. The other ones, the mood is like in like the 1% to 1%, like lower percent.
And I apologize
Mm-hmm.
asking questions.
No.
The side effects, you mentioned that
Mm-hmm.
nausea and vomiting tends to trail off over time. Do the others also trail off over time or no?
So it's very person to person dependent. Like some people will take levodopa and it won't affect their blood pressure at all. And then other people's other patients, blood pressure is a lot more sensitive, and we really do have to adjust the levodopa in order to not have those drops in blood pressure. So I can't say specifically, it is very much like each person is going to kind of tell us what road they're going to take and what their journey is going to be, and then we kind of go by their own, like each person's journey. We don't have like one way for everybody. Sometimes we can change the formulation, for instance. The levodopa comes in different formulations, and that can sometimes help with these side effects. The nausea and the vomiting, the low blood pressure, all of this can be sometimes mitigated or improved by just changing the formulation of the levodopa. And these are the different formulations that we have. So the top one is the SINEMET, which is the regular one, the immediate release, the one that has like the biggest bang for its buck and it works fast. Then we have the disintegrating tablets. So you kind of, you can chew it, or usually they just dissolve in the mouth, and that's for people that are having a lot of trouble with swallowing the pill sometimes, or even they're on and they're off suddenly and they need something that's going to work for them really, really fast. That can be like a rescue medicine. SINEMET CR, which is controlled release, and that one will slowly release over time, so it takes a little longer to start to take effect, but then it also takes longer to wear off. So some patients that have, for instance, trouble with the lowered blood pressure, that peak that the regular release causes can sometimes, you won't have as much of a peak with the controlled release, and you won't have as much changes in blood pressure. So we use them interchangeably when we see things like that happen. The next one is the Stalevo, and this one adds a third medication. So it's 3 in 1, and it adds entacapone, which I'm going to talk about in a little bit. And what it does is just tries to extend the life of the levodopa, okay? The Rytary is another one, and this one is a newer version of this controlled release. It comes in with these little beads. The capsules have little beads that also release the levodopa more controlled over time. And then we have DOPA, which is an intestinal gel that gets pumped straight into the gut, and usually it comes with a little pump. And the last one that we have that's been the most recently approved is Inbrija, and that's a powder that you inhale. It's an inhaler, and that one also is meant for like rescue therapy. It's not meant for regular use like your tablet is, but let's say as your disease progresses, you're having trouble with your on and off, and one particular day you have a really bad off episode, this one can rescue you. So it's meant for like a rescue. Okay. Any questions there?
Are these all tablet or?
So I would say the first 5 are all tablets, and then these last 2, this one's a gel and this one's a powder. That's an inhaled powder. But the rest are all tablets or capsules.
What is considered a bad off?
A what?
Bad off.
So, so with Parkinson's, sometimes you at least in the beginning of Parkinson's, you take your medication, it works, and you by your next dose, you're not feeling any change in your symptoms, right? So each medication works for you, and there's no like dip in your symptoms. An off time, what we consider, is when the medication is not working for you anymore, and all your Parkinson's symptoms come back. The stiffness, the tremors, the difficulty with balance, or slowness of movement, okay? As Parkinson's progresses over time, that off period can sometimes happen more frequently. So we sometimes have to put the doses together so that we're not running into that off time. And then unfortunately, some patients, as their disease progresses even more, will have, they're doing their daily life, and then suddenly the medication's off. So there isn't like a little bit of a wearing off, it's just they have an off. And sometimes they can freeze during these off periods, they can feel very, anxious, uncomfortable. It can be a lot of different kinds of symptoms, but usually that's what they describe. An off period that's very bad is usually a lot of freezing, uncomfortable, anxiety, those kinds of things. Difficult to move.
Are there different onset times for these different drugs and I know that's different in every individual, and are there different durations also associated with them?
You mean?
Understanding individual differences.
You mean like the medication itself, or when we should start these medicines on a patient?
Medication itself.
So yes.
Action of the medication.
So SINEMET, the immediate release, usually takes about 30 minutes to start to work, and it will last for about 4 to 5 hours in an early onset, or like early stage Parkinson's. That's usually the pharmacodynamics of the medicine. But that doesn't mean that you need to take it every 4 or 5 hours. If it's working for you every 6 hours, we can schedule it every 6. As disease progresses, like I said, your dopamine is less and less, and so you don't have a reserve, right? So you're losing your dopamine earlier than you would have, earlier in your disease. So that will shorten to maybe every 4 hours, or every 3 hours, or every 2 hours. Okay. With the other ones, the CR and the Rytary, they'll usually start within an hour. And they will usually last it a little longer, but it's kind of like the same concept. As your disease progresses, that time can vary. Okay. Like I said, there isn't a too soon. It's a very much whenever we felt or you felt that it was time to start. Research has shown that starting medication earlier isn't a negative. It's not going to affect you in a negative way. If anything, it might improve your quality of life earlier. If the symptoms are affecting your quality of life. We don't want you to feel miserable for 2 years when we could have started the medication 2 years earlier and you could have been enjoying your life, right? All right, so the next medication group that we usually tend to think about with Parkinson's disease are dopamine agonists. So dopamine agonists are different from levodopa in that it doesn't directly turn into dopamine when it gets into the brain, right? It is a chemical or a drug that activates the dopamine receptors in the brain, okay? So it's an analog of dopamine, and it activates the receptors in the brain for dopamine. And the three most common dopamine agonists that we have are pramipexole, ropinirole, and rotigotone, okay? There's other ones that are also pretty, that are a lot older, like cabergoline, pergolide, and bromocriptine, but they all have a little bit more a side effect profile that's not so good, so we generally tend to stay away from those, okay? And they're pretty old drugs too, okay? Some of them have even like cardiac and lung complications that we like to stay away from. So what about dopamine agonists? What are the things that we should know before you start or consider dopamine agonist? So one of the things that also kind of comes into this levodopa controversy is that before we thought that if we started dopamine agonists before levodopa, that was better. So a lot of the doctors, a long time ago, thought that starting a dopamine agonist was better than starting levodopa at first. That's been proven to not be true. Now experts, we no longer uniformly recommend this. We think that starting levodopa is just as good, if not better in some patients, okay? It can be used alone, so you can be on a dopamine agonist without being on any other medication, or it can be used in combination with other medications like levodopa to kind of help out with the side effects or augment the levodopa. They tend to be longer acting than levodopa, and the one concerning side effect I would say of this class of medication is impulse control disorders. And impulse control disorders falls under gambling addiction, spending a lot of money, shopping, even starting new sexual practices. It falls under that kind of category of symptoms, which sometimes is hard to identify, and the patient, themselves might not notice it until someone or a family member might be like, I think you're spending more money on, this now, or you're eating at night, a lot of ice cream compared to before, So kind of keep that in mind when you think about dopamine agonists, okay? Because a lot of these things tend to feel good, and so if you're experiencing, you might not notice it. Other side effects include excessive sleepiness, or what we call sleep attacks during the day, and that can happen, for instance, you're eating or having a conversation and suddenly you just fall asleep. So that's something to tell your doctor if it's happening while on this medication. Swelling in the ankles can happen, can also cause low blood pressure and dizziness similar to levodopa. It can cause some mood changes, and like I mentioned, the impulse control disorders, okay? And this is a more extensive list of the dopamine agonists. Apomorphine is the one that is injectable, and this one is also generally used as a rescue medicine because it works really fast, and it's the one that works the best for motor symptoms. So people who have really severe freezing episodes that they can't move, this is the medicine that's usually chosen. An injection, within minutes you can start moving again. So it's really effective for those kinds of severe off symptoms. Bromocriptine, like I said, is an old medication that we don't really use so much. Pramipexole is a big one that we use, and it comes in the regular release and then also the extended release. The extended release, we just take it one time, usually a day, versus the other one usually twice a day. Requip is the other one, or ropinirole, and Requip comes also in the extended release, and then the last one is the rotigotone, which is just a patch of the skin, and it also just releases the dopamine agonist slowly over the 24 hours. Any questions before we move on about dopamine agonists? Okay. All right, so the next class of medicines are the monoamine oxidase type B inhibitors. So we usually refer to them as MAO-B inhibitors. And this drug works to block the breakdown of levodopa. So it helps it stick around longer, and so it helps it work better, okay? And that medicine is selegiline and rasagiline, or Azilect. And these two, we use them pretty often. And the newest one that was added to this list is safinamide. But we use that one a little bit less. It's a little harder to get, you know, insurance approval and whatnot. So rasagiline and selegiline are usually our go-to. Sometimes we can use it just as monotherapy. So if you're really early in your disease, well, we might just pick this one and not start levodopa. But a lot of the time we add it on to levodopa. There is some debate about rasagiline in specific, that it might delay disease progression. There's two major studies that looked at rasagiline and if it was a neuroprotective type medicine that might slow Parkinson's down over time, and one was positive and one was negative. So that's kind of like the debate, and we don't have really good data to really say for sure that it's neuroprotective, but there is maybe some data in the literature that says maybe it does have some neuroprotective qualities. So if it's also helping your symptoms and it might help to protect you over the long run, this might be a good medication to consider, okay? In general, they're tolerated pretty well. Side effects can be headache, dizziness, insomnia, and nausea. The one thing about this medication that you do have to keep in mind is that it can have drug-drug interactions with antidepressants. And although the risk is very low for any major, problems with these drug interactions, it's something to really know. And if if you're on an antidepressant or something like that, to talk to your doctor about it, okay? All right, so the next class is the COMT inhibitors, and this falls into the other category of medicines that breaks down it blocks the breakdown of dopamine in the brain. Okay, so this one is the one that I mentioned before, the entacapone that sometimes is added to the levodopa, or the other version of it is opicapone. Okay. Entacapone is the one that we most commonly use. It's been around the longest, and it's usually dosed at least 3 times a day with your levodopa, because it'll kind of help it work longer. The opicapone, however, is the new medicine in the market, and it's just taken once a day, and it works throughout the day. Okay. Side effects for this can be nausea, stomach upset, fatigue, dizziness. It can turn your urine like bright orange, so not to be scared if that happens. And it is one of the medications that has been associated with more dyskinesia. So if you're already prone to those wiggly movements or extra movements, this might be a medicine to either consider, taking off, or talking about your doctor whether it's really the best option for you, because it can augment those wiggly movements, okay? All right, so other agents that don't really fall into either the dopamine or the extended dopamine category is amantadine. So this is an old medicine that was first developed for flu, and then they found that it helped with Parkinson's symptoms. And so it was a happenstance that it was discovered for Parkinson's disease, and since then we've been using it for Parkinson's disease and not for the flu. It can be used just alone, or it could be added on also to whatever therapy you're already on. It's helpful in suppressing the wiggly movements, the dyskinesia. So if you're having a lot of dyskinesias, this might be a medicine that your doctor will add to your regimen to kind of calm those down, okay? It can cause swelling in the ankles, discoloration in the legs, and in older individuals, we try to stay away from it because it can cause hallucinations or confusion, nightmares, okay? So age does factor into some of the decisions on when we take these medicines. Another agent is estradifylline or Nurians, and this one is an adenosine A2A receptor antagonist. and how it works, it's blocking a receptor, that receptor, and it improves Parkinson's symptoms. It's usually not recommended to be used at all alone. You usually add it on to whatever therapy you're already on. And the main, the main effect of this medication is it reduces off times. So if you're having off times in between your doses, this will help reduce that time that you're off. So it's usually considered to be added on to LEVODOPA, and it's just been recently approved in 2019. So this is probably one of our newest medicines. I think we have also like a table outside about it. So if you did want to talk to the reps about it, they're also available. One of the last medicines I wanted to talk about today are anticholinergic medications, and these medications were also really old. They were used, long time ago, and they were kind of stopped or used less often just because of the side effect profile. They have a lot more side effects. So confusion can happen, memory problems, hallucinations, dry mouth, urinary retention, blurry vision. All these are pretty prominent side effects in the more elderly patients. And because Parkinson's disease tends to occur in older populations, we've kind of steered away from some of these. But if you fall into, more of the early Parkinson's disease, these might still be good treatment options for you. One is Artane, and the generic name for it is trihexyphenidyl. And the other one is cogentin or benztropine. These usually are really good for dystonia. So if you have, tightening of the hands, curling of the toes, turning of the feet, or even, a tightening of the neck, it could be really helpful for dystonia. And it could also be helpful for tremors. But like I said, especially in our younger onset patients, not such a good option for our older patients. And that's it. Any questions that you guys had today? So I can describe a couple different patients for you, because we tend to think about Parkinson's almost like, it comes almost in like different flavors, right? So some patients, are diagnosed after 60, and their predominant symptom is tremor, okay? And that's, the kind of patient that we think of as the milder Parkinson's disease. They'll progress a bit slower, and we'll see, the progression probably over decades instead of over just a few years, okay? Then there's another flavor, let's say, of Parkinson's disease, which is the stiff and the akinetic, meaning the without movement, hard to move. So that Parkinson's tends to be a little bit more severe and progresses a bit faster. And the symptoms tend to be a little bit more debilitating or harder to treat over the long term. So their progression might be before that decade, that we think of for the tremor predominant. So if I was seeing a patient that came in to the clinic at 65 with mostly just tremor and maybe a little bit of stiffness, I would ask, and it maybe the tremor started maybe a year ago. And I would first ask, how is the tremor really affecting you? Do you feel embarrassed by the tremor? Is it affecting your day-to-day? Some patients just have a tremor where they're relaxed and sitting down. And when they're doing eating, drinking, writing, it's not affecting their day-to-day. And they're like, oh, I don't care about the tremor. It's not really bothering me. And the stiffness yet isn't so bad that we don't need to start medications. So I might say, okay, let's just watch you for the next, 6 months. And we'll kind of revisit it in 6 months and see how your tremor is and see if your stiffness is bad or if it's time to consider medicine. And usually we kind of do that either 4 or 6 months intervals in the beginning. And at any point that the patient's like, you know what, this tremor is like really interfering with my daily activities. I don't want to go out to restaurants anymore because people stare at my hands, or the stiffness is really bad in the mornings now. It's hard to get out of bed. Then it's time to start medicine. Usually we start at a pretty low dose and kind of work our way up. Standard is 3 times a day. We'll start the LEVODOPA. Usually a goal dose to start would be 1 tablet, or 1.5 tablets 3 times a day. The good dose is 2 tablets 3 times a day. But you could be anywhere between 1 to 2 to start off. And then we kind of do the same thing again. We kind of watch you. And every 6 months, we'll kind of decide whether it's working for you or not. Usually the first, we could see it that your first 5 years, we're not making big changes to your medicine. Or we're maybe just adding a 4th dose at night, or maybe just adding half a tablet per dose for those first 5 years. And then I would say after 5 years, we tend to see more changes in medicines. And then 10 forward, when we see more of the complications, and start adding more of the advanced therapies.
Thank you.
Yeah. For the stiff patient, it can be a bit more variable, and that's when we really tend to see a little bit more variability. All right. Thank you all.